A child comes to OPD, tachypnea, feeding difficulty, sweating while feeding. You think pneumonia, but liver is enlarged. Now the question is, are you treating lungs or missing a failing heart? Because heart failure in pediatrics doesn't present the way you expect. Congestive heart failure is not a diagnosis. It is a clinical syndrome where the heart is unable to meet metabolic demands or can do so only at the cost of elevated filling pressures. In pediatrics, causes differ from adults, and missing this diagnosis can be fatal. We classify heart failure broadly into systolic dysfunction and diastolic dysfunction. In systolic heart failure, there is reduced contractility, leading to decreased ejection fraction, typically less than 40%. Common causes include dilated cardiomyopathy, myocarditis, and post-ischemic damage. In diastolic heart failure, the problem is impaired relaxation. Ventricles are stiff, filling is reduced, but ejection fraction may remain normal, seen in hypertrophic cardiomyopathy or restrictive physiology. Now clinically, the most important distinction is left-sided versus right-sided heart failure. Left-sided heart failure presents predominantly with pulmonary symptoms, tachypnea, retractions, nasal flaring, orthopnea, and in infants, poor feeding and diaphoresis during feeds. Why does this happen? Because failure of left ventricle leads to increased left atrial pressure, pulmonary venous congestion, and eventually interstitial and alveolar edema. On auscultation, you may hear basal crepitations, and in severe cases, pink frothy sputum. Chest X-ray may show cardiomegaly with pulmonary edema, and echocardiography confirms reduced ejection fraction or structural abnormality. Now, if this persists, pulmonary pressures increase, and this is where the right heart comes into play. Right ventricle now pumps against increased pulmonary resistance. Initially, it compensates, but eventually fails, leading to right-sided heart failure. Clinically, this presents with systemic venous congestion. Hepatomegaly is often the earliest sign in children, followed by raised JVP, ascites, and peripheral edema. Always remember, in pediatrics, hepatomegaly is the most reliable sign of heart failure. Now coming to pathophysiology, the body activates multiple compensatory mechanisms. Sympathetic activation increases heart rate and contractility. HFrEF system causes vasoconstriction and fluid retention. Initially beneficial, but chronically harmful, because increased preload and afterload further worsen cardiac function. Now investigations should always be targeted. Echocardiography is the gold standard to assess EF, chamber size, valvular lesions, BNP or NT. Pro-BNP helps in diagnosis and severity assessment. Chest X-ray shows cardiomegaly and pulmonary congestion. ECG may show hypertrophy or arrhythmias. Now management should always be stepwise. First, stabilize the patient. Give oxygen. Maintain airway. Reduce work of breathing, then reduce preload. Diuretics like furosemide are first line. Then reduce afterload. ACE inhibitors like enalapril improve cardiac output. If there is poor perfusion, add inotropes like dobutamine or milrinone. In chronic cases, beta blockers may be added cautiously. Fluid restriction, salt restriction, and nutritional optimization are critical in pediatrics. In refractory cases, mechanical support like ventricular assist devices. And finally, heart transplant remains definitive treatment. Now exam pearls. Tachypnea plus hepatomegaly equals think heart failure. Feeding difficulty with sweating equals early sign in infants. Orthopnea equals left heart failure. Peripheral edema plus JVP equals right heart failure leads to EF less than 40% equals systolic dysfunction. And always remember, in pediatrics, heart failure is often misdiagnosed as respiratory disease. So next time you see a child with recurrent pneumonia, pause, examine the liver, because you might not be treating the lungs. You might be missing a failing heart. If this made your clinical approach sharper, Follow 5 Mine Pediatrics for more case-based breakdowns. Comment below. HF if you want a case-based MCQ series on heart failure.